Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. In this episode, we are going to discuss the uterus, the cavity that is key to embryo implantation and development of a pregnancy. First, let's understand the parts or segments of the uterine cavity and the layers of the uterus itself. The uterus can be divided into three main segments. 1. The fundus. This is the uppermost region of the uterus. The right and left corners of the fundus are the entry points to the fallopian tubes. 2. The body or corpus. This is the middle region of the uterus. This is the commonly desired site for implantation of a pregnancy. 3. The cervix. This is the lowest part of the uterus, which connects the uterus to the vagina. The uterus can be divided into three main layers. 1. The endometrium. This is the innermost layer of the uterus. The endometrium changes in thickness and consistency throughout the menstrual cycle. In the first half of the menstrual cycle, estrogen from an ovarian follicle helps to thicken the endometrium. In the second half of the menstrual cycle, progesterone from that follicle, which is now called the corpus luteum, helps to change the consistency of the endometrium and prepare it for implantation of an embryo. 2. The myometrium. This is the muscle layer of the uterus, actually made up of 3 layers of muscle. This layer of the uterus is very strong and able to expand and contract. For example, with pregnancy, it expands a whole lot, and postpartum, it contracts back to its normal size. 3. The serosa. This is the outer layer of the uterus. The uterus can sit in 2 different positions in the pelvis, which are described based on the tilt of the fundus and body of the uterus, either towards or away from the bladder. An anteverted uterus is when the fundus and body of the uterus is tilted towards your abdomen or bladder. A retroverted uterus is when the fundus and the body of the uterus is tilted backwards, away from the bladder and towards your spine or tailbone. Now that we have reviewed the normal structure of the uterus, we can speak about some congenital and acquired anomalies affecting the uterus, which may affect fertility. First, let's discuss congenital anomalies. Congenital means these are factors existing from birth. They did not develop throughout your life. These congenital anomalies are due to an issue in the development of the uterus. Normal development of the uterus occurs from growth and fusion of 2 tube-like structures called Müllerian ducts. Think of this as 2 halves of a normal uterine cavity that need to come together, fuse, and then have the middle or central wall get absorbed by the body to give a single uterine cavity. If this process of fusion and absorption does not happen or happens incompletely at some stage, it leads to a congenital uterine anomaly. Congenital uterine anomalies can be divided into 6 types. 1. Uterine agenesis. This is also called Meyer-Rokitansky-Kusterhauser syndrome, or MRKH syndrome. This is where there is a very tiny uterus or no uterus at all. It is not possible to carry a pregnancy in these cases, and thus a gestational carrier or gestational surrogate is needed in these cases. 2. Uterine didelphys. This is where the 2 Müllerian ducts did not fuse together, leading to 2 smaller uterine cavities and 2 cervices. It is possible to conceive and carry a pregnancy in these cases, although there is an increased risk of preterm birth. 3. Bicornuate uterus. This is where the 2 Müllerian ducts did fuse together, but only partially at the lower end. This leads to a uterus made up of 2 horns that are fused together at their lower end, and there is a deep indentation at the fundus between the two horns where fusion did not occur. It is possible to conceive and carry a pregnancy in these cases, although there is an increased risk of preterm birth. 4. Unicornuate uterus. This is where only one of the Müllerian ducts fully develops into the uterus, giving a smaller uterus, which appears like a single horn. The other Müllerian duct is underdeveloped completely or partially developed to give what is called a rudimentary horn. It is possible to conceive and carry a pregnancy in these cases, although there is an increased risk of preterm birth. 5. Uterine septum. This is where the two Müllerian ducts fuse together, but the central wall did not get fully absorbed, leading to a partial or complete uterine septum, depending on how far the wall extends from the fundus to the cervix. It is possible to conceive and carry a pregnancy in these cases, although there is an increased risk of miscarriage, often thought to be due to the embryo implanting on the septum and getting inadequate blood supply to allow the pregnancy to develop. A uterine septum can be surgically corrected, where a small telescope-like camera called a hysteroscope is inserted through the cervix and into the uterine cavity, and the septum is shaved or cut down very carefully. Surgery is not always needed, so this really requires a discussion with your physician. They will take into account the depth of the septum as well as your fertility and pregnancy history to decide if surgery would be recommended for you. 6. Arcuate uterus. This is where the two Müllerian ducts fuse together and most of the central wall was absorbed after fusion, but a very small bit of the wall did not get absorbed, leading to a small dip or indentation at the fundus of the uterus. This indentation is usually less than 1 centimeter in depth. It is still possible to conceive and carry a pregnancy in these cases, and this is not associated with an increased risk of miscarriage, as seen with a uterine septum. Acquired uterine anomalies can be divided into 3 main types. 1. Uterine polyps. These are essentially overgrowths of the inner lining of the uterus, or the endometrium. They are usually benign or non-cancerous, especially in young people, but can sometimes be precancerous or cancerous. These are often asymptomatic, found on ultrasound done for another reason, but can sometimes cause symptoms, usually irregular spotting or bleeding, or heavy menstrual cycles. Some risk factors for developing polyps include elevated BMI or obesity, certain medications such as tamoxifen, and postmenopausal status. Polyps have been associated with fertility issues, depending on their size and location in the uterine cavity. They may be associated with decreased pregnancy rates and increased miscarriage rates. If someone is facing fertility challenges already or planning fertility treatment, it is usually recommended to remove polyps to optimize the uterine cavity and give the best chance of pregnancy, naturally or with fertility treatment. Some exceptions may include a tiny polyp, for example, less than 0.5 centimeters, as you could pass this with your period, or a polyp that is in the lower part of the uterus, close to the cervix, as this is not where we want a pregnancy to implant. If a polyp is causing symptoms like irregular spotting or bleeding, it's also usually recommended to have it removed. 2. Uterine fibroids. These are overgrowths of the muscle layer of the uterus. They are usually benign or non-cancerous. Fibroids may be asymptomatic, but common symptoms include heavy periods, prolonged periods, and painful periods. Pressure symptoms from large fibroids are also common and include pelvic pressure, bloating, and frequent urination. Some risk factors for developing fibroids include race, as they are more prevalent among Black people, and family history, as they are more common in people with a family history of fibroids, for example in their mom or their sister. There are various types of fibroids to be aware of, including subserosal fibroids, intramural fibroids, and submucosal fibroids. Subserosal fibroids sit in the outer wall of the uterus and are thought to have little impact on fertility, but may be otherwise symptomatic if they are large, for example, giving frequent urination, pelvic pressure, or abdominal distension. Intramural fibroids sit in the muscle wall of the uterus and are somewhat controversial. Some studies have shown that larger ones, usually greater than 5 centimeters in diameter, may possibly affect fertility, but this is not always the case. It is important to weigh out the risks and benefits of surgery and its possible complications prior to any treatment. Submucosal fibroids sit in the uterine cavity, partially or completely. When a submucosal fibroid is sitting completely in the cavity, it is called an intracavitary fibroid. Submucosal fibroids have the most well-established effect on fertility as they directly distort the uterine cavity. They may decrease implantation and thus affect pregnancy rates, and they may increase the risk of a miscarriage. Thus, these are the ones that are generally recommended to be removed to optimize a uterine cavity and pregnancy rates. 3. Uterine adhesions. These are areas of scar tissue that form between the inner walls of the uterus. Picture bands of tissue forming between the inside walls of the uterus that may be thin and flimsy or thick, significant bands. This intrauterine scarring or adhesions is sometimes called Asherman syndrome. Depending on the amount of scarring, adhesions may be asymptomatic, but the most common symptom is lighter periods, or in the most extreme cases of scarring, no periods at all. Intrauterine adhesions are often due to previous surgery in the uterus. For example, a D&C for a miscarriage or a termination, or a cesarean section, or removal of a fibroid. Less commonly, adhesions may be due to an infection of the uterus and the uterine lining. So now that we have discussed what the uterine anomalies are, let's dive into diagnosis and treatment of these. There are many ways to image the uterus to help diagnose a congenital or acquired anomaly. Ultrasound is a good starting point to get a general sense of the uterine shape and possible lesions. Often 2D ultrasound is used to start, but 3D ultrasound can be quite helpful. A sonohystogram is also an ultrasound, but one where saline or salt water is instilled into the uterus in order to separate the inner walls of the uterus and be able to better visualize the shape of the uterus and identify any structures within the uterine cavity. It also helps us assess the fallopian tubes, but I'll leave that for another episode on the tubes. When shape of the uterus or diagnosis of a congenital anomaly is not clear, MRI can be used to further delineate the uterine cavity. Surgical diagnosis with laparoscopy or hysteroscopy were once considered the standard for diagnosing uterine anomalies. Laparoscopy involves inserting small instruments and a telescope-like camera into the abdomen to examine the uterus and its external shape. Hysteroscopy involves inserting a small telescope-like camera through the cervix and into the uterus to examine the inside of the uterus for its shape and the presence of any lesions. Surgical diagnosis is not needed as much nowadays, given the advances and options in imaging we now have. Surgery is important, however, in treatment of uterine anomalies. Treating congenital and acquired anomalies may be necessary to improve fertility and also to treat other symptoms. Uterine septum is the only congenital anomaly that can be treated surgically for fertility. Hysteroscopy may be used to resect a uterine septum, as mentioned earlier. Hysteroscopy may also be used to remove acquired lesions, including uterine polyps, submucosal or intracavitary fibroids, and uterine adhesions. Now that we have addressed and discussed uterine anomalies, let's move on to some common questions I am asked about the uterus. The first one is related to the position of the uterus in the pelvis. My uterus is tilted backwards. Will that affect my chances of pregnancy? You can still get pregnant with a tilted or retroverted uterus, and this should not affect your pregnancy rates. Once sperm is ejaculated in the vagina, it will quickly find its way to the uterus, regardless of whether your uterus is tilted forward towards the bladder or backwards towards your tailbone. Another question I hear quite often: is there a test of the uterus that I can do to see if I have an implantation issue? I hear this question a lot, especially after IVF and a failed embryo transfer. Unfortunately, at this time, There is no standard of care test to identify an implantation issue, the way we do ovarian reserve testing for the ovaries, or a sonohystogram to assess the uterus and fallopian tubes, or a semen analysis to assess the sperm. But this is an evolving area of research and testing. I've already seen tests being widely used for some time, and then not being used because of new evidence, even just in the last 5 years, showing how quickly things are changing and evolving as research is done. I'm often hearing about new tests for implantation, but they are largely research-based or very new, with limited evidence to support their widespread use. Polyps are another hot topic. I am often asked, do I have to remove my polyp before trying to conceive or before doing fertility treatment? People can conceive and have an uneventful pregnancy with a polyp present. This is true, I've seen this, but studies also show that a polyp in the mid-body or fundal region of the uterus can affect implantation and pregnancy rates, as well as miscarriage rates. That is why it is often recommended to remove polyps if you are trying to conceive and facing difficulties, or if you're pursuing fertility treatment. The idea is to optimize the uterine cavity and improve pregnancy rates, whether you are trying naturally or doing fertility treatment. That said, if you have not tried to conceive yet or are very early in your fertility journey and the polyp is very small, less than 0.5 centimeters, or in the lowest part of the uterus, close to the cervix, it is not unreasonable to leave it alone and see if you conceive or end up passing the small polyp with your period. I also hear about a lot of fear and worry around a sonohystogram test, or sono as it is often called. Will the sonohystogram hurt? Unfortunately, I hear this question a lot, largely because there is a lot of negative commentary around this test on the internet. The truth is, the sono is a crampy and uncomfortable ultrasound test. For most people, it feels like their period cramps. For a small number, it is less than that. They report minimal or no discomfort. But for a small number of patients, it is quite crampy and painful, more than their period cramps. I think it is important to be aware of this discomfort, but not be scared of it. It is brief. The procedure itself generally takes less than 5 minutes to complete. Taking ibuprofen or acetaminophen, if you are able to, before the test can help reduce the pain or discomfort. So there you have it. All about the uterus. First, what is normal for uterine shape and the layers of the uterus? Second, the different abnormalities either existing from birth or acquired at some point in life. Third, how we can diagnose these abnormalities and treat them if necessary. I hope this episode was useful in allowing you to better understand the uterus and the various abnormalities that may affect the uterine cavity and your pregnancy potential. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.